You know, when you think about it, a medical chart is really just a story, but it's written in a very specific universal language. Today, we're going to be code breakers. We're going to decipher that secret language used to describe everything, and I mean everything that can happen to our body's largest organ, the skin.
So just take a look at this. You've got the epidermis, the dermis, all the glands and follicles. It looks pretty straightforward, right? But this surface, it's basically the stage for thousands of different conditions. And medical coding, well, it gives every single one a unique identity, so that healthcare professionals anywhere in the world can understand a patient's story with just a glance.
So here's our game plan. First, we're going to introduce the codex itself, the rulebook. Then, we'll dive right into the nitty-gritty of rashes and drug reactions, explore the surprisingly intricate world of ulcers, unpack the narrative of infections like cellulitis, and wrap it all up with how we code the actual repairs.
Okay, so where do all these codes actually live? Well, our guide for this whole journey is a system called the ICD-10-CM, and we're zoning in on Chapter 12. You can think of it as the ultimate dictionary for classifying every disease of the skin and the tissue right underneath it.
And you know, its scope is actually way broader than you might think. It's not just about skin. This chapter also gives us the codes for everything connected to it. Yep, that includes the sweat glands, our hair, and even our fingernails and toenails.
All right, let's kick things off with one of the most common reasons anyone ever sees a dermatologist: a rash. We're jumping into dermatitis, but more importantly, how its story is so often tangled up with the medications we take.
So what is dermatitis, really? You've probably heard it called eczema. It's just a general term for skin inflammation. Now, it can be triggered by something you touch, like an allergen or an irritant, or, and this is so important for coding, by something you took internally. A medication that was supposed to help, but, whoops, caused a reaction instead.
Now, before a coder can even think about assigning a code, they have to answer one critical question. Was the drug used correctly? If a patient has a reaction to a drug they took exactly as the doctor ordered, that's an adverse effect. But if that drug was taken incorrectly, maybe the wrong dose, or it wasn't even their medicine, that's a poisoning. And trust me, that distinction changes everything. Okay, so let's look at how this plays out. When you're coding an adverse effect, the main character of the story, the reason the patient is there, is the reaction. So the reaction gets coded first. You see it right here. The code for the dermatitis comes before the code for the penicillin that caused it. The problem being treated is the rash itself.
But now check this out. This is where it gets really interesting. For a poisoning, we tell a completely different story just by flipping the sequence. Here, the primary problem isn't the rash. It's the fact that the drug was used incorrectly. So the poisoning code comes first, and the rash, the dermatitis, is listed second as the consequence. It's the same drug, the same rash, but the sequence of codes tells two totally different stories.
All right, next up, we are moving into one of the most detailed and honestly challenging areas in skin coding, ulcers. And these aren't just simple sores. Oh no, they are complex conditions that demand incredible precision to document correctly.
In this table right here, it perfectly illustrates a core rule, especially for non-pressure ulcers. An ulcer is very often just a symptom. It's the tip of the iceberg of a much bigger systemic problem. Whether it's atherosclerosis, diabetes, you name it. The code for that underlying condition has to come first. You have to tell the why before you can describe the what.
Speaking of details, pressure ulcers are typically classified by stages that tell you how deep they are. But every so often, a coder runs into a tricky situation. They'll see a diagnosis for an unstageable pressure ulcer. So what on earth does that actually mean?
Well, it means the wound bed, the bottom of the ulcer, is completely hidden. It's a deep, full-thickness injury, but it's covered by dead tissue. That's the slough or eschar. It's like trying to see the bottom of a murky pond. You just can't determine the true depth, so you can't assign a stage until all that gunk is cleared away.
And this just goes to show how much these little nuances matter. For instance, a Kennedy ulcer, which can appear very suddenly near the end of life, isn't coded as a pressure ulcer at all. It's coded as a traumatic injury. And if an ulcer gets worse over a hospital stay, you always code for its most severe stage. You even have to make a distinction between an ulcer that is currently healing versus one that is fully healed. Every detail changes the code, and it changes the story.
Now let's take this whole idea of sequencing and apply it to another really common condition: cellulitis. In this story, the question of what happened first is everything. The sequence of codes isn't just a rule here, it's the entire plot.
So cellulitis is a widespread bacterial infection of the skin. Pretty simple. But Bacteria can't just get in on their own. They need an entry point. They need a doorway, a cut, an ulcer, a surgical wound. And that is the real beginning of the story. It dictates everything about how the encounter gets coded.
So let's look at case number 1. Someone's out hiking, they get a nasty cut on their leg, and a few days later, it gets infected. What's the main reason they're in the doctor's office? It's the wound, the cut itself. That's why the code for the laceration is the principal diagnosis, and the cellulitis gets listed second as a complication. But now, contrast that with this scenario. A patient develops cellulitis at their incision site a week after an operation. Here, the story isn't really about the incision. The story is about a complication of medical care. So the principal diagnosis becomes infection following a procedure. Then you add the codes for the cellulitis and the specific bacteria. See, the context is king.
Okay, so we've diagnosed the rashes, the ulcers, and the infections. Now we have to code the fix. Let's wrap up by looking at the procedures used to actually repair the skin. Things like debridement, excisions, and grafts.
Debridement is just a fancy word for cleaning out a wound, but how it's cleaned makes all the difference in the codes. If a surgeon takes a scalpel and literally cuts away dead tissue, that's an excisional debridement, and it's coded under excision. But if they're just washing, scrubbing, or brushing it away, that's non-excisional, and it gets a totally different code under extraction.
And it's a similar story for removing a lesion. Coders have to know the difference between excision and destruction. Excision means you are physically cutting the thing out. Destruction means you're obliterating it right where it is, maybe with a laser, or by freezing it, or burning it off. Two completely different actions, two completely different codes.
And for huge repairs like skin grafts, the code has to answer a really important question. Where did the new skin come from? Was it autologous, meaning from the patient's own body? Was it non-autologous, maybe from a donor? Or was it totally synthetic? The code tells that whole backstory, and there are even special codes just to keep track of patients who have artificial grafts.
This quote really says it all, doesn't it? The order of the codes is never arbitrary. It's a narrative, and it's built around the single most important reason for the patient's care. It's all about telling a story that is medically precise and factually accurate.
This whole intricate system, it's a hidden language that guarantees clarity and accuracy in healthcare all around the world. It really makes you wonder, doesn't it? What other complex, totally essential languages are operating silently all around us, structuring our world in ways we hardly ever notice?